Professor Aysegul Sahin from USA. Professor Sahin is a faculty member at MD Anderson Cancer Center since 1988. Section head of breast pathology and director of education in the Department of Pathology and Breast Pathology Fellowship Program. She's also the director of the Breast Tumor Bank. She has published over 290 peer-reviewed manuscripts on breast pathology, especially on morphologic features of invasive and in situ carcinomas, as well as high-risk lesions, biomarkers of breast cancer progression. We're honored to have you, Dr. Sahin, today.
Thank you. Good afternoon, ladies and gentlemen. First, I would like to thank all the organizers, especially Professor Manal. I don't see her, but for inviting me. It's always great pleasure for me to participate in this conference. We are going to talk about metastatic tumors in the breast. This entity used to be a rare entity in breast pathology, but now with the presence of effective therapies in many solid tumors, now the biology and clinical behavior of these solid tumors have changed, and the patients live longer, and then they developed metastases in unusual sites. And especially in breast, we see these smaller and smaller biopsies, and sometimes it's very difficult to really differentiate the primary versus metastasis. I love the picture that Dr. Quinn showed us, the two bricks. And this is going to be like those two bricks. When you see an invasive lesion in the breast, is it a primary or is it a metastasis? Sometimes it's impossible to differentiate. To illustrate that, I would like to show you a case, which is a 62-year-old woman who was found to have a 1.2 centimeter mass and underwent an ultrasound-guided core biopsy. And this biopsy was performed outside, and this is the lesion. As you can see, there is an invasive epithelial process, and based on cytology, it is an invasive carcinoma. And the outside pathologist made the diagnosis of invasive ductal carcinoma NOS, and they performed tumor biomarkers, which we do ER/PR, HER2, and Ki-67. And this PR staining was interpreted as positive. And the patient was referred to MD Anderson Cancer Center, and we reviewed the outside slides, and we agreed with the diagnosis. But in terms of calling this PR positive, because it was ER negative, HER2 negative, we felt a little uncomfortable based on this diffuse cytoplasmic staining. And based on this, we said, okay, let's get the outside block and repeat the biomarkers. But I reviewed the case, and I said, yeah, it looks like invasive ductal carcinoma. So we made the initial diagnosis, and now we say the biomarkers pending. And when we are trying to receive the outside block to perform the biomarkers, she had a chest CT because she had some progressive dyspnea. And then on the chest CT, an ill-defined lung density was identified, and she had an FNA of the hilar lymph node, which was positive for metastatic carcinoma. And of course, when she went to our final aspiration, with the diagnosis of patient has a primary breast carcinoma, and then we were thinking that, oh, is this a metastasis from the primary tumor? Meanwhile, we received the breast biopsy, and this is the results of the breast biopsy. So the tumor was TTF1 and napsin positive. And so it really changed the entire diagnosis, and this is a metastatic adenocarcinoma of lung in the breast. So as I said, these are rare. When you look at the big cohorts, it is less than 5% of all breast malignancies. And if you look at the autopsy incidence, again, in the United States, we don't have extensive autopsy series anymore, but it is definitely less than 10%. Even in patients with a history of malignancy presenting with a single breast mass, a secondary primary breast carcinoma is always more common. So no question that when you have a biopsy of breast lesion, and if it's a single lesion, and if you want to bet on it without looking at the slides, bet on the primary tumor. But always remember the metastasis. When you look at the incidences from different sites, malignant melanoma is the most common solid tumor if you exclude the hematopoietic neoplasms. Lung cancer, ovarian cancer, gastrointestinal, and genitourinary tumors, they all can present as a metastasis, but melanoma is always the most important mimicker. Among men, prostate can happen in 5%. And if you look at the autopsy series, the incidence is higher. In children, rhabdomyosarcoma is the most common metastatic tumor. It also depends on the demographics. For example, in the Korean woman, the GI tumors in Asian women is a lot, the incidence is higher. So the gastric cancer is #1 in Korean women, and malignant melanoma in the Australian population. And in the United States, from the two major cancer centers, we have recent publications, and this is from Memorial Sloan Kettering results. And again, melanoma is the most common. And this is the MD Anderson series we published 2 years ago with 238 cases. Again, melanoma is the most common metastatic tumor in breast. The majority of the cases of extramammary malignancies metastatic to breast have a history of primary malignancy. The unfortunate thing is that even though the patient has a history of malignancy, the primary physician who refers the patient to mammography and the radiologist who performs the biopsy doesn't know about it, or they don't put it in the request. So when we receive the biopsy, we don't have the history all the time. The average interval is about 50 to 60 months, but now this is changing. You know, many melanoma patients, especially with immunotherapy now, they are surviving a lot longer, and they developed unusual metastases. Breast metastasis is the initial presentation in 1/4 of the patients. So there are some patients who have malignancy occult, and then the metastasis is the initial presentation. It can be single or multiple. Bilateral lesions can occur, and enlarged axillary lymph nodes can be encountered. And frequency of axillary lymph node involvement is higher in the series that include lymphomas. And this is, again, from our series. It can occur in both females and males, but it is more common in female. Regardless of the origin of metastatic lesion, they present at a single rapidly growing mass. Sometimes they can have nipple discharge. And it's very important that sometimes they mimic inflammatory breast carcinoma symptoms. So they have the swollen, erythematous breast with skin thickening. So it is very important not to confuse it with inflammatory breast cancer. Unlike primary tumors, the mass is usually superficial without skin involvement. Typically, they are described as a well-circumscribed mobile mass, but sometimes they are just like primary breast tumors. There is no specific imaging findings. In some reports, the absence of microcalcification is considered to be a characteristic, but there are many metastatic tumors, such as thyroid carcinoma, ovarian carcinoma. They can be associated with microcalcification. So just because we have microcalcifications doesn't exclude malignancy. Recognizing a breast tumor as being metastatic is obviously crucial for appropriate treatment, and the diagnosis can be challenging on corneal biopsy. And if you are not going to remember anything, please remember this last point. There is no specific clinical, radiologic, or morphologic feature. So it's really, they mimic each other. In general, when we say if it's a solid high-grade carcinoma, and if it lacks in situ carcinoma, if it has extensive lymphovascular invasion, we say think about metastasis. But do we have primary breast carcinomas showing this? Yes, we do. So there is significant overlap in terms of these features. And this is our study that we published last year. And in that, we had 16% of the cases, the breast metastasis was the first clinical presentation. And of course, I'm not very proud of this, but this is the reality. 41% of these patients, our initial diagnosis was wrong. So even in a cancer center, we have a specialized practice. If we don't know the primary tumor, 41% of the time, the initial diagnosis was wrong. In contrast, if we know the history of primary tumors, our misdiagnosis rate was 2%. So this is the table from our paper showing that the most important thing to get the diagnosis right is knowing the history. If we know the patient's history, then we get it right. But if we don't have the history, almost 50% of the time we get it wrong. And this is another case. It's a 63-year-old with 2 separate masses here, and 10% of breast carcinomas initially they present with multiple lesions. So yes, when we have multiple lesions, our index of suspicion is high, but it's not specific. And here is the diagnosis. It's a high-grade malignancy. And when you look at retrospectively, you may say, well, there are some pigmented-looking cells, but at the time we didn't appreciate that, and it was a metastatic melanoma. As I said, metastatic melanoma is the most frequent lesion, and in general, when we teach pathology to students and residents, we say melanoma is always the greatest mimicker. And this is another study published in the literature looking at 18 cases. And look at the initial diagnosis. Great majority of them were misdiagnoses, either carcinoma or lymphoma or other diagnoses. Another case is a 62-year-old woman who had a mammogram showing 2 separate nodules, and the corneal biopsy was performed on both of them, and it was invasive ductal carcinoma, and left mastectomy was performed, and diagnosis of invasive carcinoma, ductal carcinoma was made. She had adjuvant therapy. And this is her lesion. And it had the solidness and areas of retraction, and some of the areas were interpreted as DCIS, associated with invasive cancer, And we said this is the solid component of invasive cancer. And 2 years later, she had some abdominal discomfort, and based on that, she had a CT and MRI, and there were multiple lesions in the liver, and there were also nodules with calcifications in the small bowel mesentery, and CT-guided biopsy of the liver mass was performed, and here is the liver lesion. And when you look at the lesion, it was CDX2 positive, chromogranin, synoptophysin positive, and based on her breast history, we performed gross cystic disease fluid protein 15 immunohistochemistry, and it was negative. So we went back to do breast lesion, and it had the same immunophenotype. So initially, we thought this was an invasive ductal carcinoma, but actually it was a neuroendocrine, metastatic neuroendocrine tumor. And based on the clinical features, we said it is probably small bowel origin, based on the CDX2 positivity and imaging findings. So these misdiagnoses can occur, and metastatic neuroendocrine tumors is one of those lesions. And this is our series that we published, and most of the lesions that metastasized the breast was from small bowel. And in 18 cases we reported in this study, 8 of them, 44%, was initially misdiagnosed. And one very important thing to remember is that if we are thinking of neuroendocrine tumors in the breast, the primary neuroendocrine tumors are usually ER/PR positive. So if you have a ER/PR negative neuroendocrine tumor, please think of a metastasis. And based on morphology, these lesions are very similar. Here is a metastatic carcinoid, primary neuroendocrine tumor of the breast, solid papillary carcinoma, and adenoid cystic carcinoma. Morphology is very similar. So think of Dr. Quinn's bricks. They really look, in terms of their morphologic features, is very similar. So you really need to think about metastasis. Another case, 72-year-old female with palpable right breast mass. She had an ultrasound-guided corneal biopsy, and it is associated with microcalcifications and papillary serous looking tumor, intermediate grade. And in this, differential diagnosis is definitely invasive ductal carcinoma with micropapillary features, invasive ductal carcinoma with tissue retraction artifact, or metastatic micropapillary carcinoma from GYN, lung, or bladder origin. And when we checked for additional history, the patient had a serous borderline tumor of the ovary 5 years prior to her breast biopsy. And she had very high level of CA-125, and her abdominal MRI showed these multiple mesenteric nodules and retroperitoneal lymph nodes. And the tumor was diffusely positive for ER, negative for PR, high Ki67, and it was negative for GATA3, PAX8, and WT1 were positive. So based on this, we said it was a metastatic serous carcinoma of Mullerian origin. So the serous carcinomas and micropapillary pattern is another pattern that when you see it on especially core biopsy, it is indistinguishable from each other. So you definitely need to think about a Mullerian primary or other primary tumors and do the appropriate immunohistochemistry. Again, this report from MD Anderson, out of 18 cases, we had 22% of the cases were misdiagnosed initially. Another tumor pattern that we have to be really cognizant about and think about metastasis is illustrated in this case. Again, a 62-year-old woman had a mammogram, screening mammogram on April 2021, and she had a ultrasound-guided biopsy. And it shows this diffusely infiltrating neoplasm going around normal lobular units, and high magnification showing these individual single cells. Some of them have signature cell morphology. And then we did echoterine, and it was positive. So then we said it is most likely an invasive carcinoma, NOS. And it was ER negative, PR weakly positive, and patient was scheduled for segmental resection with sentinel lymph node. Meanwhile, patient had this progressive abdominal discomfort, and she presented to our emergency room. She had an abdominal CT, which was really non-specific, but the GI colleagues recommended endoscopy. And in endoscopy, she was found to have these enlarged fold, and gastric biopsy was performed. And this is her gastric biopsy, showing tumor cells very similar to what we found on her breast biopsy. And it was CK20 patchy, but in areas it was strong. And CDX2, again, patchy but strong positive. And then we went back to our breast biopsy, and this is her breast biopsy. Again, similar immunophenotype, and we made the diagnosis of metastatic gastric signature cell carcinoma in breast. But if she did not present with her GI symptoms, we would have been happy with her invasive carcinoma with signature cells in breast, and she would have had the treatment for primary tumor. The expression of biomarkers sometimes overlap, especially progesterone receptors can be expressed in some GI tumors and lung tumors. It's really important to put both morphology and immunophenotype together. And in last case, we had another unusual patient who presented with a 2 by 2 centimeter single breast mass. Corneal biopsy was performed, showing this cartilaginous lesion. And it was pancytokeratin focally positive, CK7, 5, and 6 were negative, vimentin was positive, rare cells with P63 and melanoma markers were negative. So we said, well, it could be metaplastic carcinoma, because sometimes in core biopsy, when you don't have the epithelial component, you don't see keratin positivity. It could be, if it is breast, it could be metaplastic, what could be metastasis. So let's try to do additional markers. Meanwhile, she had additional imaging studies, and she had both lung and kidney lesions. And she had a renal biopsy, and the renal biopsy showed very similar morphology, and the diagnosis was renal cell carcinoma with sarcomatoid features based on this immunohistochemical profile. And we went back to the breast biopsy, and it showed the same thing. So it was a metastatic sarcomatoid renal cell carcinoma, metastatic to breast, metastatic to liver, and breast mass was actually the initial presentation. So in summary, like wide variety of tumors with wide variety of morphologic features can present in breast. And when we look at the breast lesions, as I said, there is no specific morphologic features. There's no specific clinical or imaging features, and there is no specific breast marker. In the past, we always did GATA3, gross cystic fluid protein, and myoglobulin, but their sensitivity and specificity, especially in hormone receptor positive versus hormone receptor negative tumors, is very variable. None of the markers is 100%. Especially in triple negative breast carcinomas, the sensitivity of both myoglobulin and GATA3 are quite low to be diagnostic. And we know that GATA3 can be positive in many other tumors, and we have seen in our clinical practice that the tumors were GATA3 positive, and based on that, primary breast carcinoma diagnosis was made, but the patient had something else, a thyroid tumor. So 2 years ago, we published this study, and we, in our clinical practice now, use this routinely. It is the TRPS1 marker. We identify this marker through our TCGH database search, and then we were trying to find a breast-specific marker. And this is GATA3 comparing to the messenger RNA expression in the TCGA. As you can see, that the expression of GATA3 and TRPS1 is very similar to each other. TRPS1 stands for trichorhinopharyngeal syndrome, and the gene is located on chromosome 8. And it encodes a transcription factor, which is a GATA-type zinc fingers. And the germline mutation of this gene causes this hereditary autosomal dominant disorder, characterized by these facial features and sparse lateral eyebrows and pear-shaped nose. And it's a nuclear staining. The antibody works beautifully, and we use this now to identify triple negative breast carcinomas in conjunction with our GATA3. And when you look at the overall comparison, GATA3 versus TRPS1, overall it is a lot more sensitive compared to GATA3. If you look at the ERPR positive tumors, it is very comparable. So if you look at only hormone positive tumors, GATA3 is an excellent marker. So is TRPS1. And similarly for HER2 positive tumors. But when you look at the triple negative breast carcinoma, that is where the importance of TRPS1 comes in. 88% of our tumors that we did in our initial study and our subsequent studies that they are positive, and then GATA3 is positive only 50%. And this is for metaplastic triple negative breast carcinoma. And in overall, the TRPS1 maintains high sensitivity in both metaplastic and non-metaplastic triple negative breast carcinoma, with sensitivity a lot higher than GATA3. So now in our clinical practice, we use this extensively. And in terms of TRPS1 expression in different tumors other than breast, we have seen a rare weak expression in urothelial carcinomas and lung carcinomas, and it is negative in thyroid and renal cell carcinoma. So again, it is not 100% specific, but it is very sensitive marker. The other marker that I would like to mention, and this is the first public presentation of this marker, we're going to present it at the upcoming USCAP, and our manuscript is just submitted and it is accepted, so I don't have the publication number yet, but it is going to be in human pathology. It is SUC17. It is one of those SRY-related gene, and it's a transcription factor. It plays important role in variety of developmental events, including endoderm formation, cardiovascular, and germ cell development. And recent studies indicate that it is involved in tumorigenesis, and we again identified this marker through TCGA, and it is present predominantly in GYN tumors. Especially in ovarian carcinoma, it is co-expressed at intermediate or high levels in about 90% of serous and endometrioid carcinoma and 100% of clear cell carcinoma. So if our differential diagnosis becomes between the GYN and breast tumor, then we are using SUC17, and with a SUC17 positive, it is not breast carcinoma. So this is another marker that we are using. And WT1 can be rarely positive in breast carcinoma, so that's the reason we are using SUC17 as a conjunction. And the first one was ovarian carcinoma, and this is endometrial carcinoma. And as you can see, compared to PAX8, the sensitivity of SUC10 is a lot better. When you look at the other tumors which are PAX8 positive, SUC17 the staining is negative. So it is going to be an important expression in our IHC panel. But most importantly, breast tumors are negative. So it definitely overcomes the pitfalls of lack of specificity of PAX8 for GYN tumors. So in summary, when we have a tumor that we probably rule out the metastasis from a known primary tumor, based on the primary tumor, we make our immunohistochemistry panel. And then the two new markers that we are including now are the TRPS1 and SUC17. So diagnosis of metastatic tumor should be considered with patients with known extramammary malignancy. And comparison of previous diagnosis is essential. Panel of IHC markers can be used, and TRPS1 is a highly sensitive marker to identify breast primary. Thank you very much for your attention.
Thank you so much, Dr. Sahin, for this interesting talk, and which highlights that we don't live in an island with our microscope, and we have to extend our bridges to the clinical settings to help us in the diagnosis. Thank you very much. And now we proceed to the next talk.
Thank you.